pleased to introduce Anne-Marie McLaren, who is a registered chiropodist and adjunct professor at Western University in the Master of Wound Healing program. She's a lecturer at the University of Toronto in the Department of Medicine and the Lawrence S. Bloomberg Faculty of Nursing in the area of diabetic foot complications. She's an active participant in clinical research and co-investigator with Diabetes Action Canada. Anne-Marie has served as an invited expert in the development of wound care quality care standards and health technology assessments for Health Quality Ontario. She's an active member of the College of Chiropodists of Ontario, founding executive member of ONTWIG, member of the Registered Nurses Association of Ontario Wound Care Institute, and an educator for the Wounds Canada Diabetic Foot Canada. She's a member of an interdisciplinary wound care team specializing in the high-risk foot, limb preservation, and advanced wound care, and I'm pleased that she found time to spend some with us. Anne-Marie.
Hi, everyone. Just stand. Good morning, folks. I'm Anne-Marie. Thank you very much to Wounds Canada for inviting me to speak. The offloading piece is near and dear to my heart. I do a lot of it. So hopefully I can share some clinical pearls of practice with you guys who are working with diabetic foot ulcers. I have no conflicts to disclose. At the end of this presentation, I'm hoping that you guys will be able to identify some of the common etiologies of why people get diabetic foot ulcers. I'd like to show you an idea of being able to select an offloading device by where the ulcer is located, as well as to describe some of the pressure offloading devices and their effect on the foot. So one of the things we can look at when it comes to pressure and pressure offloading, it's really force over area. And a lot of the ways that you can look at it very simply is intrinsically the inside of the foot, so the bony structure and what's happening inside. And here I'm showing a picture of this really here is the bone structure of a toe deformity and how that toe deformity can also cause a number of diabetic foot ulcers, not only on the top of the toe, the tip of the toe, but also the metatarsal head. So the biomechanics of how a foot works from a foot structure piece can be a source of problem, as well as the extrinsic side of things, the outside part, the fact that you have gravity, the patient walking on and the ground pushing up against the feet. So the fact that people are walking is a source of pressure, right? And here I'm showing a picture of a patient that came into clinic to see us who had multiple hyperbaric dives, had been undergoing foot ulcer care for about 3 months, but nobody really looked inside the shoe, and footwear is an extrinsic piece that we need to be looking at. And here you can see an example of how somebody actually had a bolt right through the sole of the shoe into the insole of the foot and basically corresponded to where the ulcer was and why they had that diabetic foot ulcer, which circles back to us talking about the idea that with peripheral neuropathy, people can't feel that. So the idea that they have to be checking their shoes. How many people have found weird and wonderful things in shoes? Yeah? I know. Anybody want to share something as far as what they found? Pardon? Dentures. Dentures. Oh, that's new. I've never heard that. D.
I had a gentleman who played a full round of golf with a golf ball in his shoe.
Wow, golf ball. Yeah, so it's common to find things like that. So we need to make sure patients are checking their shoes. So what could we do about pressure? We can try to identify the cause, like remove the golf ball, remove that piece from the shoe. And here you can see that foot where the wound was in the center part of the arch, which is kind of an odd spot for an ulcer, right? So again, we need to kind of remove that cause if we can. We need to redistribute forces if we can. Now, intrinsically, it's tough to do that unless you have bone surgery, right? But we can focus a lot on the extrinsic types of things. And we need to work with the patient to find the best solution, because it's best to have the patient on board with these things. Now, here we have number one, the total contact cast. These are the kinds of offloading devices we have available. And now we have best practice guidelines driving which one we should choose. So we know that the total contact cast is the gold standard. And number two, the removable cast walker. And that's the knee-high device. And that's the gold standard for treating an active neuropathic diabetic foot ulcer. Number three is an example of a half shoe. And number four is a therapeutic footwear with a custom insole. Now, out of the group here, how many people are actively using these types of devices in their practice? So a good number of you guys. Okay, that's great. So what I'd like to share with you is Suzanne Liu, my colleague, is here in the audience. Suzanne, would you stand up for a second? This is my colleague. Her and I run a diabetic foot ulcer clinic once a week in a tertiary care facility. And these are our outcomes I wanted to share with you guys. If you talk about tips and tricks about why and how we do things, Suzanne and I looked at our healing outcomes and our wounds. We had 267 people with 332 wounds. We healed over 80% of them. So we have a published paper on that work and how we did it, and I wanted to share with you guys how we do that. One of the things we found that so if we were looking at what was statistically significant, we found that wound location, we actually healed more midfoot wounds. That was statistically significant. We also healed a lot of forefoot wounds, and surprisingly enough, a lot of hindfoot wounds, which in the hindfoot, often 80% of those end up with an amputation. The one thing that we did find statistically significant in our patients who attended our clinic and did go on to wound healing was they had to have a palpable pulse. And then we also looked at the use of a total contact cast, which, not surprising, we know from the literature, healed the most amount of people. And the healing sandal healed the least amount of people, which makes sense. And then the removable cast walker healed statistically not bad against the total contact cast. So some of the tips and tricks I'd like to share with you now is basically our recipe. This is how we look at offloading patients with diabetic foot ulcers, and this is in our paper. Basically, we look at the mechanics of how the foot structure works, and you can see the yellow part is the lesser toe. So if we have wounds on the lesser toes, we would be selecting either a short removable cast walker, a healing sandal with a solid rocker sole, or a custom device and shoe. Now, if it falls in the first ray or the metatarsal head area, which is the blue area, so understanding where is the diabetic foot ulcer, and we're talking mostly around neuropathic foot ulcers here, we would select a total contact cast, a tall removable cast walker, plus or minus an insole modification. So sometimes we'll modify the inside part of the the cast walker. And then when we look at the midfoot, so that's kind of the Charcot deformities that you might see, where the foot's changed shape and is rocker soled. That we would consider in the green area. And again, thinking about location and bone structure, for those folks, we either choose a total contact cast with or plus or minus a modification of the insole. So we actually cut out an area where that ulcer is, or we use a tall removable cast walker with an insole modification. And then the really difficult ones are the hindfoot wounds. And with those folks, we usually use a total contact cast with a modification, or a healing sandal with insole modification, or non-weight bearing. So it depends on working with the patients, what resources we have, but this is sort of our gold standards around how we do it. And Suzanne and I wanted to share with you our recipe for that. The other thing that we do with total contact casting, we kind of encourage all of our patients to do that. I basically position it like this. Today you fell off your front step and you've broken your leg. You need a cast. What do we need to do to get you in this cast? How do we manage that? So we look at that piece. The other thing is, I would say, the whole piece around removable cast walker, I say we shouldn't tell them they can take it off. It could be an adjustable cast walker, but who told them they could take it off? So now we don't remove those. We write our orders for wound care, and we actually make, can you guys hear me? I think I lost my voice. Oh, it slipped? I noticed that. I think I've lost the mic. Yeah. Basically, what the other thing is that with the removable cast walkers, we don't tell them they can take it off. And we only do that when they do the dressing changes. So that's some tips and tricks around that piece. When here's a case of a forefoot wound. This person had diabetes, loss of protective sensation. They had a wound on their foot for 3 months. They had pedal pulses, they had no infection, and the cause was an ill-fitting shoe. It was over the third metatarsal head. Here we're total contact casting, and we used a rubber knob. We do all kinds of fancy things with casting. So we use the basic casting technique here. And here you can see how at baseline, sorry that's not too clear, we always forget to take pictures of a lot of our wounds. This is at 2 weeks, and here you can see it closing at 4 weeks. And then here I wanted to show you just a quick picture. Right now we're working on a study looking at pressure mapping, and this is a Padar system. That's me in a total contact cast with a stirrup on. And here's the picture of where the pressure mapping goes. So just to give you guys an idea of what happens about pressure redistribution, you can see that, if it was in the pink or red zone, it would be an extreme amount of pressure, but what you can see by me wearing that total contact cast with the stirrup on, there's quite a bit more pressure on the heel, but it's still significantly less, right? So we've reduced it, so we've shifted. So what you're doing with any kind of pressure redistribution is you're moving pressure from one place to another. And that's why patients get transfer lesions, which we're going to touch on in the next presentation. But this just kind of gives you an idea of what's happening when somebody's wearing a cast, where the pressure goes. Okay, so that's me with the cast on, and this is a pressure mapping system of me wearing that cast and walking and where the pressure goes. So the key takeaway points I would say is that you really have to be looking internally and externally around the forces of pressure, and really that's a combination of looking at loss of protective sensation, foot deformities, the mechanics of how people walk and move, right? Ambulation in the ground, the fact that people are walking a lot, and what kind of footwear they're wearing. And that the ulcer location is often the result of excessive peak pressure. So if you looked inside your shoes right now, you would see areas where you had peak pressure just by dynamic impression. And that's basically telling you, chiefly like a pressure mapping system, here's where the most amount of pressure is. So really the key about this is you're just moving it somewhere else, okay? And the goal is to always redistributing pressure because the forces change. So if you lose a toe, the force is going to be somewhere else. If you're going to put it on one leg, you're shifting it to the other leg. So you're always moving pressure around. So it's a bit of a moving target, and patients are always changing, and the foot structure is always changing, right? Here's some references if you guys are interested.
I'm going to invite Amanda Mayo. Dr. Mayo is an amputee physiatrist at Sunnybrook Health Sciences Centre. She's an assistant professor and clinician in quality improvement in the University of Toronto Department of Medicine. She provides wound care to amputee and diabetic foot ulcer patients and is a member of the multidisciplinary Sunnybrook Limb Preservation Team coordinating patient rehab care and providing expertise on optimizing patient function. Her primary research focused on improving the quality of life and health outcomes of dysvascular amputees. Dr. Mayo.
Thanks, Andrew. I think my intro is longer than my talk, so. So yeah, I hope I answer some of the questions that maybe didn't get a chance to be asked, but really I'm going to come from a rehab perspective for some other tips and tricks for offloading, because definitely I see a lot of these patients, and I'll stick here because I don't think the other mic was working. So I'm Amanda Mayo. I work for Sunnybrook Health Sciences Centre. I'm really an amputee physiatrist, so that's a rehab physician that sees amputees both prior to surgery and after surgery, and I don't have any relationships with commercial industry. So we're going to work through a few cases, and these are actual patients that I've seen in my service, and really recognize the complexity because, like you said, we can offload these patients, but the ulcers are going to recur. We can also offload these patients and they fall, they can't enter their home, they can't drive. There's other things that we need to look at besides the wound and the foot. So there's really a lot of implications when you're offloading the wound in clinic with a total contact cast or a removable cast walker. So you really need to consider, and I take that your question, like what is the underlying pathology? A lot of these people have bones, their metatarsal heads have dropped. If that ulcer heals, they're still dropped. You need to fit them in something, and I know it's not affordable for a lot of our patients, that will prevent the ulcer from recurring because it is a high recurrence rate. You also have to go higher than the foot. You have to look at their ankle. So what's their ankle range of motion and what's their ankle strength? Because as you mentioned, the diabetic neuropathy will also cause motor weakness, and the first thing that it hits is dorsiflexion. So when you're looking at your foot, you have to test dorsiflexion strength because they're going to be dragging that foot along when they're walking, and that's putting a lot of increased load on the foot and the ankle. Where do these patients live? So often, they're offloaded, but they have stairs to do, so they're going to take that cast walker off because they can't use it on stairs. It's not going to give them that push off to get up to the next step. Maybe they need to drive to work. You have to think about different things about how they're going to live their life while they're in their total contact cast for, over 6 weeks. This wound is not going to heal quickly. And what do they need to walk? So often, maybe they didn't walk with a cane or a walker, but now they need one. And in the most severe cases, maybe you need to totally offload with a wheelchair. Oh, and rehab. So rehab is important. And, these people are usually very deconditioned, and the last thing I want them is just laying in bed with their cast and their walker. You should be getting them moving. You should get their fitness up, and maybe improve their mortality, improve their heart and lung function, and that will also, impact the way that their wound is healing. So I'm going to run through some cases, and hopefully it'll be interactive. I am biased. A lot of my cases don't have all their digits or their limbs. So this first one, and mostly, if it's the picture, they're mostly male, they're mostly diabetic. They mostly are on ODSP, Ontario Disability Support System, or haven't been working for some time. We are finding the age is dropping, so a quarter of our patients now on the amputee service are under 65, which is very alarming. So this guy is 70 years old. He's a diabetic. He has a partial foot amputation, as you can see. Not all the toes are there. He's wearing only shoes. So he comes in, he's wearing a regular shoe, and he's walking on this, and he still has these ulcers, so you can imagine. So that's a huge ulcer in the bottom of his plantar aspect. But what is his other diagnosis? Like, why does this foot not look like a foot? I hear it. Yeah. So this is a chronic Charcot arthropathy. And I don't know if you can notice, but he has a really skinny shin. Like, he has 0 dorsiflexion. He's like 1 out of 5 at best. So how are you going to offload this guy? He's also a contralateral BK, just to complicate things. So he's got a prosthesis on the other side. Yeah, Anne-Marie got it. Well, does anybody know what a crow is? So there actually is a walker for Charcot foot. And of course, Charcot, there's 4 stages, and when they're acute, you might have them in a total contact cast. But when they're chronic, they need something. They have a rocker bottom sole, they've dropped their navicular head, they're gonna keep ulcer and lead to amputation. So that's what we fit this guy. And it's funded, at least in Ontario, by the Assistive Device Program. It doesn't fund everything, it funds 75%. The patient's portion is still in excess of $300, so it's a lot of money for these patients. But it really offloads, and it has a rocker bottom sole, so this guy could walk. He actually walks at a very good clip with no gait aids now, with his BK prosthesis and his crow walker. So it is a good option. It is removable, then they're allowed to remove it, especially for hygiene purposes. And for him, because he also has the partial foot, we just put a custom orthotic on the inside, so that's also protecting the partial foot amputation. Okay, number 2. This is a shared patient with my esteemed colleague, Dr. Casey. So he had a right-sided partial foot amputation. Poor balance. There's also probably, and the other thing to consider with these patients is a high number have vascular dementia. So there's always a mild cognitive impairment that's probably lingering. And so their insight, their decision-making skills are often not 100%. And to complicate things, he had a contralateral Achilles rupture. So he had his partial foot amputation. And so if he has a contralateral Achilles rupture, he can't hop. He has no plantar flexion on the other side. So this is what he was sent home from our acute care site. The removable cast walker, and a set of axillary crutches. So how do you think he did? Dr. Casey. So he didn't do well. And I mean, we could probably predict this, and that's why I think, we're looking at these patients and how we're going to treat them. We need to build better steps for success. So if he's not able to hop before the surgery, he's definitely not going to be able to hop after the surgery. He needed the cast walker to offload his wound to allow it to heal, for sure. But it was also the right side. He can't drive. So how is he, and the goal, the initial plan for this guy was to see me in outpatient rehab. We were going to do wound care, work on balance training and reconditioning, but he just couldn't make it. So he called me in panic. He's like, I can't get to clinic. I can't get to rehab. So I have the luxury where I admitted him to inpatient rehab, and we really worked on his transfer training and stairs. He had to do stairs at home. He lives in a 2-story house in Toronto. And we introduced a new gait aid for him, which was a knee walker. This one is good for some patients, definitely the one with the wheels can get away from patients, but it was an option for him where he could at least get in and out of his house and go to doctor's appointments. So he ended up being a success after 9 months. So it was a lot of wound care, TLC. He's now walking without any gait aids with a custom orthotic, which of course wasn't covered by the government program, but he was fortunate to have private insurance. He does use a single point cane for longer distances, and he has diabetic accommodative shoes. And he's still being followed closely because I think he's still at risk for ulcers, and especially on the other side. And he's participating in an outpatient falls and balance program. And this is just my last slide, and I'm going to credit Morty Eisenberg, because when I first started at St. John's Rehab, he said, if you do not offload the other foot of these amputee patients, you're being negligent. I would say almost 80% of my diabetic amputees that are coming to amputee rehab have a contralateral posterior calcaneal ulcer. They have not been offloaded while they're waiting in bed for rehab. So this is your best friend. Something to offload the other foot, and even maybe it's in the outpatient setting. So if they have that cast on that other leg or a removable cast walker, you need to think about the other side, because they're going to be laying in bed, they're not going to be moving, and something else is going to happen. So that's sort of my end point. So takeaway point, it's not just the foot. You got to look at that ankle. You got to look at where the people live. And patients benefit from balance retraining, gait aids, and you might want to consider a home care OT home safety assessment if they're not coming to inpatient or outpatient rehab. Thanks.